everyone. Welcome to this Genomics England webinar. My name's Vivian Parry and I'm Head of Public Engagement at Genomics England. And today we're going to be talking about neurological conditions and particularly about the value of the National Genomic Research Library, the NGRL. We'll come to what that is and what it means in a little while. Now, if you don't know of Genomics England, although I know some of you will because you'll have come through the 100,000 genomes program, and that was set up to look at people with undiagnosed conditions and some cancers. And that was a project that Genomics England was involved with in partnership with the NHS. And now there is a genomic medicine service in the NHS, and we finished the recruitment, though obviously we're still continuing to look at the genomes of those who entered the 100,000 Genomes project. So let me introduce our panel to you, or some of our panel. Let me introduce, first of all, Henry Holdon. Henry is at the UCL Queen Square Institute of Neurology, and he specialises in the genetics of neurological disorders, and all the way from California, but actually not from California in terms of academic departments. It's Professor David Rowich, who is neonatologist, developmental neuroscientist, and head of the Department of Pediatrics at the University of Cambridge. So I'm going to start with Henry. Henry, tell us, what is the National Genomic Research Library?
Well, this is a very important tool to both us and patients. But what it is hundreds, well, probably about 130,000 now, patient whole genomes that are anonymously categorized into a large library that's searchable with brief clinical details and all of their genetic details to allow us to research this and find new genes and new genetic associations. So it is a big library of consenting patients' genetic material that we can anonymously work on and find important new genes on. That's what it is to me. Now, it may be different things to other people, but I'm really interested in new genes and genetic associations.
Now, all the people who came into this were people who had undiagnosed conditions. And one of the things that we're going to talk about today is we're going to talk about cerebral palsy, which was actually not one of the conditions that we thought about originally. But it's exciting to think that we can now use this data to look at something that we never thought was possible before. And as we go through this, for all of those of you listening and watching, we will be taking questions. So do put those in the question bit. Don't put it in the Q&A, just put it in the question bit, and we'll take those as we go through. So Henry is very interested in looking at the different genes. David, what's your interest in the NGRL?
I guess I'm a neonatologist, so part of my clinical practice is resuscitating babies that may be born preterm or have had a difficult delivery. They are at risk for developing cerebral palsy. And so as part of our research, we will try to understand the root causes that can result in cerebral palsy with a view to developing better treatments. Are there ways we can protect the brain against injury or support better repair after an injury has occurred? So that's been the traditional view in my field, is that, these birth injuries or maybe something in utero has contributed to the foundation of cerebral palsy. The genomic efforts like Genomics England, NGRL, decipher developmental disorders have started to show us that there are genetic contributors to some people with cerebral palsy. That completely changes our understanding of what might be the root cause. So that by employing genomic tools like whole genome sequencing to patients with undiagnosed conditions can provide us these very unexpected insights into the cause of their condition, whether it was inherited, many questions that are very important to patients and families. So it really is transforming our appreciation of the causes of cerebral palsy.
Not cerebral palsy, but Henry, the data set has already been extraordinarily useful in uncovering completely new conditions. And there's one in particular that I'd like you to talk about, which is it was not your particular work, but some of the researchers who've been using that data. And then that's RNU42. Tell us about that.
Sorry, Viv, I missed the last bit. Just repeat that.
So this is the some of the things that we have discovered that weren't known before, and particularly this RNU42.
Yeah, you're right. So new genes have been found using the library, and the way researchers have approached that, you can either work on this genomic resource, or you can come to this resource looking at families that you've recruited and patients you've recruited as part of your research program, and then almost to put the two together to gain greater genetic power. But the beauty of the genomic library is that you capture the genomes, which contain intronic regions as well as exonic. So this is
intronic. Just tell us what intronic
I'll
means.
tell you what that is. So the exonic bits are the bits that make protein. The bits in between the exonic bits that years ago were thought to be just redundant DNA were often neglected and ignored. But the beauty of having the whole genome is we have those bits to work on. And this particular gene is very important in splicing, and was revealed to be in a region that we couldn't have captured before. So, for example, I looked at our exonic data set, and we would have missed this gene if it hadn't have been for the whole genome data library. So I think it's a very important way of picking up new genes using this resource.
And actually, it may be that's really a very important discovery, isn't it? The RNU42, because it may be responsible for as many people as Fragile X's and previously completely unknown.
Well, it's diagnosed a whole group of patients that were for years undiagnosed. And as Alex will probably tell you later, you know, having an undiagnosed child or a young adult is very difficult because you're all the time searching for a cause. And I think this has diagnosed many patients and families. So this, like other rare disease genes, is very important.
And David, are there any particular successes for you from the NGRL already?
Well, could I just pick up on this last point because it gets to what sort of test is maybe best to use, a whole genome sequence or a whole exome sequence? In the United States, it's more accessible to get whole exome. That would have missed the RNU4-2, which is in the space between the genes, if you will, that's not picked up by whole exome sequencing. So I think it really makes a very strong case for a whole genome as being the type of test that you'd like to be able to use. From the clinician's point of view, if we look at the babies who may be admitted to natal ICU, information such as understanding that about 1 in 4 of them will have a genetic condition will change our practice of neonatology. With the finding that 1 in 3 children in pediatric ICU, it's such a common thing that the NHS decided to stand up a national service. It's called the R14 pathway for NICU and PICU. And so now that is a tool that's generally available in the NHS. That's a great asset to care because we can look at ways to provide the diagnosis, as Henry suggested, better manage the care because we know what to expect, and there may be even precision medicines. A great example is for seizures, where if we know it's a genetic cause of a seizure in a baby or a child, we may change the anticonvulsant drugs they're on because we know that some work better for that particular genetic diagnosis of seizure. So it really is having a substantial effect on our ability to provide high quality care, especially for those kids that are coming to hospital.
So Henry, these are babies that present with a problem when they're very tiny, soon after birth. They automatically in the UK get offered whole genome sequencing, but it's different for those people who have undiagnosed conditions. How do they go about requesting genome sequencing for their child?
Yeah, so in the UK, as David alluded to, we have the benefit of being able to do a whole genome using consent from the parents, and including the parents as a trio. So this is a very powerful way to pick up a mutation that's in the affected child, but not in the parents, called a de novo, or a new mutation. So we're in a privileged position to do that, but of course we need to understand the clinical features. So in the cases of a cerebral palsy patient, we need to put those details together with the genetics, together with the patient's parents' blood for whole genome, and they have to consent. And the consent is a very important process. And it's not just consent to pick up a particular mutation, but consent to understand that the whole genome will be sequenced. Now, not every country in the world can do that. As David said, in America, it's exomes. In Europe, I think it's predominantly panels. I think David may be able to open that up. But I think we're in a bit of a privileged position to do this.
But some of these people who have their child clearly has something, and they'll have a whole genome sequence, and the answer will come back as negative. But negative doesn't really mean that there's nothing there. Perhaps a better way to put it, where it's not actually clever enough to know what it is yet. So how do parents proceed when that's the case? There's initially negative result, Henry.
Okay, I understand. So genome negative patients, that's when they have the genome and it comes back as negative. Of course, new genes are found every year. So we really need, and we don't have this going perfectly in the NHS, where we don't have the staff to go back every year and check for new genes. I think we need to have that done every 1 to 2 years. So to go back, and when somebody's had a negative genome, is that negative for new genes? Well, no, because the genome only reports on known genes that the NHS has put in a particular panel of genes. So if that's negative, but we can also think about going to new technologies such as long read sequencing. And long read sequencing is something I've been using on a research basis to try and diagnose the undiagnosed.
So long read sequencing is exactly like it says on the tin. Instead of breaking up the genome into little short bits, you break it up into much longer bits, and that gives you perhaps more detail than or more accuracy than with the short reads.
Yeah, it's like doing a jigsaw puzzle with really big pieces instead of doing a jigsaw puzzle with tiny pieces, which is what a short read genome is. And it makes it easier for us to define and find the very difficult genetic causes, such as these repeat expansions. So the really difficult things we can pick up. And that's what we're using long read sequencing for. And then it's a question of collaborating with other groups to try and replicate our findings.
Now, I know that with the NGRL, if a new, we have an absolutely wonderful lady called Susie Walker, who looks at the genomes. And if there is a new finding, she will see if there are other genomes with the same condition, and the clinicians get told. But that's people who are undiagnosed. And I want now to go to those who do get a diagnosis. David, what's the impact, as far as you're concerned, of having a diagnosis for these people with neurological disorders?
Well, there are a couple levels we can look at that. Henry's mentioned the so-called diagnostic odyssey, where there's a struggle to try to find a diagnosis, repeat evaluations, and going to different specialists. A diagnosis sort of ends that diagnostic odyssey and puts you more in the frame of what could we possibly do about this? And I think this is, again, where there are new opportunities opening up to think about precision medicine. That could mean repurposing drug. One example being how we might change anticonvulsant drugs for a genetic diagnosis that accounts for epilepsy. Gene therapy will be another class of precision medicines. And when you have a diagnosis of a genetic condition, that could make you eligible for a gene therapy clinical trial. And I think there's a tremendous opportunity in the UK as we start to systematically identify patients with genetic disorders, and maybe almost an obligation to provide them with options such as participation in clinical trials that could, potentially benefit them. And there, are these really remarkable therapies that have come into the frame for immunodeficiency, for a condition called spinal muscular atrophy. Really, you might have said 20 years ago, kind of hopeless conditions that now offer some prospect of benefit through research and after having had a genetic diagnosis. So this is what we can look forward to. One example I'll give just from cerebral palsy is in our experience of now starting to offer through research whole genome sequencing for people with cerebral palsy, seeing in particular cases where we would change care because we've made a diagnosis. And that's what I think we can look forward to happening more and more in the field of pediatrics, where we'll be making these diagnoses.
I want to turn now to another of our guests today, Alex Golap. So Alex, welcome, and you're in New Jersey at the moment, so thank you for joining us. And I wanted to talk to you because you turned a diagnosis into a spectacular thing. Where you got involved with researchers and you did all sorts. So just tell me about your son Raymond and what the return of a diagnosis meant to you. I have to show you my special mug, Alex.
So my son Raymond is 8 years old, and he received a CP diagnosis at the age of 2. And although I always knew that he was probably a rare kiddo, I took that CP diagnosis just to get the services that I knew that would benefit him in the long run. And, now having that diagnosis, diagnostic odyssey, get us to a diagnosis, has been life-changing for me. It's been a learning process of, understanding the world of research that I never expected to go into. And it's just given us, a little bit more hope for the future in making a difference in the lives of others. And yeah,
So tell us about Vamp2. So Vamp2 is the particular variant that causes Raymond's problems. So how did you start this kind of, I'm going to call it a Vamp2 Collective, it's where you started to talk to other people about it?
Honestly, I don't like to use the word messy, but it's been disorganized. Where we started is, feels like forever ago. But when we got the Vamp2 diagnosis in June of 2020, I was guided to a Facebook group that was started by a mom here in the US. And when I went into that group, I, was just kind of watching what everyone was doing. At the time, there was less than 10 people in the group. And I just, our journey with Raymond has had a lot of positives. There's been negatives, but we have gotten him to a point where, he's doing okay. And there was just a lot of families that I felt didn't have the proper resources, didn't, know how to help their kids maybe at some time in their journey. And it just made me want to take our journey and turn it into a positive and reach out to researchers, find papers, and just educate myself to start an advocacy group to ultimately help all these kids and not just Raymond.
So one of the people that you reached out to was Henry Holdon. Henry, tell me why you welcomed this approach from Alex and what it's meant to your research.
I think what it's meant is not only to our research in terms of finding more patients and families that are willing to be involved in our understanding of how this gene causes Raymond's problem, but it's diagnosed many other families. It's opened up awareness, and it's also opened up research as well. So Alex has helped many families using her website. Many patients have been in contact with us. We've understood about the spectrum of problems that this Vamp2 can cause. And we also understood about what treatments, or we're starting to understand what treatments work and what don't. So I think there's diagnosis, there's understanding, there's treatments, and there's also highlighting this gene to try and think about how we tackle more effective treatments. So a number of areas.
So one of the things that patients are absolutely brilliant at is they're brilliant at connecting with other patients, and not just in their own country, but all over the world. And what does that mean, Henry, when someone like you gets, instead of the few that you might see normally at UCL, compared to when you've got absolutely, well, I'm going to say masses, but not not that many masses in with Vamp2. But how does that make a difference?
Well, I think it makes a difference in terms of our confidence that certain defects in that gene cause this disorder. So we're all the while in genetics questioning and trying to prove as best possible that a gene mutation can cause the disorder. And we try and be 100%. And the more families you have with a particular mutation, the more clinical details you have makes you much more confident that you've got the right gene and you know what it does and you know how this gene, or you can then think about and work on how this gene causes the disorder. And we've done a lot of functional work to try and understand this. And we've collaborated here with another group at UCL, for example, to make a mouse model to then work on therapies in this particular gene. So it's taken it a lot further.
And Alex, how has it been for you working with researchers?
Very overwhelming. I'm very lucky that Henry and the team at UCL and some of the other groups, they've been with me since even before the website got published, before my foundation got formed, and they've educated me throughout this process. And that's just taken it to a whole nother level. It's driven my passion even more. It's made me want to help and actually go out and find patients, trying to use this story as an example that there's not just one way to get these types of projects off the ground. You have to meet everyone's, you have to make everyone feel comfortable. And that's something that we've struggled with in our community. I'm not in this for money. I don't want to get paid, to help our group. I want to inspire people that there's answers out there. We just have to work together to find them to help, not only research, but our own kids and families.
Well, you're doing a great job, Alex, because A, you're super inspiring, and B, you've actually shown what can be done by patients actually assembling together to advance the cause of their particular genetic variant. So you get 11 out of 10. It's been great. So let me now go back to what we were discussing earlier about cerebral palsy research. So for many people, that if you just stop somebody in the street, they'll think of cerebral palsy as being associated with prematurity, perhaps, or problems with blood supply to the brain around the time of birth, that kind of thing. And while some genetic causes were known to be associated with cerebral palsy, the idea that genes had a bigger role to play in cerebral palsy was something that was really dismissed. But that's now changing, thanks in part to work that is able to be done now with data sets like the NGRL. So let me go back to David, just first of all, and say, David, just give us the overview of how this has happened. What has made people reassess cerebral palsy?
There's been an international collaborative effort to examine the impact of cerebral palsy. Studies in Australia, Canada, America, China, and also investigations within the UK that collectively are starting to show us that as many as 40% or as few as 11%, there's a variation in studies. People diagnosed with cerebral palsy that have a genetic condition. And then that allows for the reassessment, as we sort of heard from Alex, opening up avenues for research, this potential for precision medicine. So this really is a case of international collaborative efforts, academic and clinical colleagues from around the world having discussions, and now probably a reassessment within the pediatric neurology community of just what the impact of genetics is. And that's where I think people like Anna Basu, a pediatric neurologist at Newcastle, might be able to comment on how, from her point of view, this may be impacting the assessment of such children.
Before we come to Anna, just to ask Henry, how did Genomics England first start getting into this work, and what are the other initiatives that are looking at cerebral palsy?
Well, I think as we know that cerebral palsy is not a particular panel on Genomics England, and that's something that we're developing. But we know that patients in Genomics England have been sequenced with the clinical features of cerebral palsy. So it's come out of finding genes using the National Genomic Library that fit a cerebral palsy diagnosis. So it's kind of evidence is built up. The frequency of patients with cerebral palsy with genes are increasing. And now, of course, you go back to that and you see a frequency, some people say 30%, some people say higher in some series. So it's brought from results using this data set to find patients with genetic defects.
And what are the other initiatives that are around?
Well, some of the other initiatives, such as we're trying to develop a particular panel of clinical features of cerebral palsy that encompass all patients, if we can, with cerebral palsy, so that we know which genes to look for. So a faster way to take a patient with cerebral palsy and then look at a particular group of genes. Of course, you might say, well, that will always be increasing. Well, it will be, but we have to deal with the genes we have at the moment to try and increase the speed of diagnosis. That's one. So panel of symptoms, speed of diagnosis, and then using some of the new technology on the undiagnosed families. So there are many genome negative cerebral palsy families that we still need to use the long read sequencing on.
So there's what Genomics England is doing, but there's a much wider initiative going on, and that's Neuronet. I'm delighted that we've got two people associated with Neuronet from different ends of the country. So first, Dr. Anna Basu, who's a paediatric neurologist at the University of Newcastle, and Dr. Heather Pearce, hello to you. Heather is a genetic counsellor who's associated with Neuronet, kind of they're netted together, Cambridge to Newcastle, and she's, as I say, based in Cambridge. So Anna first, what are you doing with Neuronet? What is it exactly?
So, well, this is a study that I'm helping to recruit to at Newcastle, and there are a bunch of other sites around the country. So essentially, the idea is to find patients in clinics who have cerebral palsy, and to ask the families if they're happy for the child to undergo basically a whole genome sequencing testing through this research avenue to see if there is a genetic cause for that. So and then it's a very nicely set up study because there's some easily accessible information for families to access to understand what would happen. Essentially, the child has to have a blood test and ideally both parents, and then there's some data that's collected to understand what the phenotype is, and also what I like about it is that the test is done quite quickly. So I'm just going to raise this because this you can get a turnaround in around 3 months for this, and actually that is good because something we may need to come back to is how long it takes to get results. But so then there's also some exploration of what that experience is like for families, which is being captured. So basically, hopefully, it'll give us a clear idea of, in the UK setting, what diagnoses are we finding in this group of patients.
And Heather, what's your role in Neuronet?
So I'm a genetic counselor, research genetic counselor who's worked for years and years in the clinic, but have just started to work completely in research. And part of my interest in the project, and I work mostly in the recruitment of patients, but I also worked with patient engagement prior to the project happening. So what we wanted to know was, well, is this something that is actually acceptable to the parents, to the families, to do this type of genetic testing? Because it's not something that's really been done in cerebral palsy in the UK before. So even the initial sort of pre-study interviews that we did with families of patients and relatives of patients and carers is that there was quite a positive acceptance of the possibility of genetic testing, as long as it could potentially provide some benefit to the family, to the patients. But also in recruiting patients, part of my role is to help to explain to them, just as Anna had said, exactly what to expect from the study itself, explain a little bit about genetics, what it means to get a positive, or find something that might be causing some of the cerebral palsy symptoms, but also what it means to get a negative result, or even a variant of uncertain significance in some cases. And so I think it's really important for patients and families to really understand exactly what to expect before they make an informed decision about whether they actually want to undergo genetic testing in the first place. And then we also support the physicians feeding back those results. If they feel like they need some additional support in doing that, we can provide some of that help in feeding those results back. And I'm also sort of instrumental in designing the questionnaires and looking at the feedback from families about their experience of undergoing genomic testing, whether they find it useful, how we could do it better, what we could do differently. So that's how I'm involved.
Because there are lots of things to think about, aren't there? Because you go into this thinking, at last I'm going to get an answer, but we need to make sure that people understand that most people will not get a diagnosis. Is that right? Some people will, but most will not.
And I see that you want to respond.
Yeah, I mean, that's right. I mean, that's probably true for a lot of the genetic tests that we do actually do in mainstream. So, like when we test babies with epilepsy, then, it's about a third or more maybe that do have a diagnosis from it. So, yeah, so it's comparable to other conditions where there are panels and routine testing now. That you don't expect that everyone's going to get a diagnosis from this.
But even the families that we've worked with, a large proportion who don't get a definitive diagnosis, where they get what they call a negative result, still feel like it's important to participate in the research because they want to improve the understanding of what's going on in these families. And so they're not just doing it for themselves. They're doing it for the greater understanding, because they know other families are going through exactly the same types of things. And so I think even if you know that you're not necessarily going to get a diagnosis, doesn't necessarily mean that the research won't be useful to you.
And Henry, the very fact that the people that enter this have their genomes then sitting in the National Genomic Research Library means that there might in the future be a diagnosis. I mean, there might not, but there might be as our knowledge increases.
Yeah, that's I think patients quite like that, to understand that their genome is there. It's anonymous, but it's there for researchers like me to work on. And it may not only help them, it may help others in the future. So I think that kind of having a genome in the bank there will always have the opportunity for a diagnosis as the years go on. So I think everybody should be encouraged for that to happen.
David, we've got a question that's come in. And by the way, do please put in questions. We're very keen to help answer them if we can. The question here, have you found any patients with a GLUT1 deficiency diagnosis who have a cerebral palsy diagnosis through genetic testing?
I'm not aware of that particular association. It may be Anna is another person who can comment. I mean, GLUT1 is a diagnosis that we would make not uncommonly. I don't think it's on our list, though, for cerebral palsy genes. Anna, did you want to?
So it's kind of often presents slightly differently. So you can have some it's a variable phenotype. Sometimes there's a little bit of learning difficulty. Sometimes there's some movement disorders. Some things like paroxysmal dyskinesias. And so I guess it must be relatively unusual for a presentation clinically to be a CP-like presentation. So I'm not aware of of patients in Newcastle who have been diagnosed as CP and then for any other reason then got a diagnosis of glute-1 deficiency. But I don't know. I mean, I'd be interested to know whether, because if you're from glute-1 deficiency UK, whether you've seen that.
Perhaps that you could put that in the question and answer bit. But you've taught Henry a lot about panels. So there are different ways that we talk about panels. So one of the things that Genomics England does is it uses panels. So if your main presentation is, for instance, or I don't know, a bleeding problem, then there's a panel for that kind of thing. If it's an epilepsy that the patient has, then they'll be look at that panel. So how are those panels put together and how are they updated?
So they're based on evidence that this gene causes the particular clinical phenotype. For example, the glute-1 gene would be on a movement disorder panel. Patients get a dystonia or a movement disorder. And those panels are there to help guide the diagnostic service to rapidly look at those genes in that patient to give them a diagnosis. And they're updated based on this panel app. So this Genomics England panel app, which is based on people inputting evidence as to the pathogenicity of a particular gene or not, as the case may be. But it's very helpful to the diagnostic lab to have that, to allow them to look at those known and proven genes and then to report on those known and proven genes, because you don't want to report on a gene that's totally unrelated to the patient, because that could cause problems that are not there and we should never look at. So it's always very important to be guided by the genes to report.
But if there's someone who comes in with, let's say, their main presenting symptom is epilepsy, but actually the cause of their condition is something that's associated with movement disorders, does that mean people can get tested for the wrong thing and therefore get missed?
No, well, the beauty of having your whole genome is you can choose one panel, say when the patient has a movement disorder, it can give you a gene that causes a movement disorder and an epilepsy. So you may be able to look at the patient and then be wary of what other clinical features are going to come along. But also having a whole genome means that you can add panels. So if, say, you saw this patient with epilepsy and then you saw them again and they had a movement problem, you might say, well, let me ask the lab to do this movement panel as well. And you can go back to the genome and allow you to do that much more quickly than having it done in the first place.
Yeah. Could I just add, I mean, I think, as Henry says, the genome really has all the information. It's just how we selectively might look at it. But it's there to, so finding for, let's say, an epilepsy could provoke a question about a cardiac condition that might go along with such a gene mutation. We can just now either do the cardiac screen, or we could look further for information in the genome to make a diagnosis of a syndrome that maybe puts it all together. The epilepsy, the cardiac comes together now because it's known to be associated with that gene. So it's a very helpful tool to answer questions about, is there a genetic cause? Of course, we've sort of hinted at the fact that there are other ways to make diagnoses beyond genetics, and those are also new tools that we'll be thinking about for the future. But genetics is such a useful starting point to answer these basic questions and try to make a diagnosis.
There's a helpful question here from I hope I'm pronouncing your name right, Thiloka Ratnaika. I want to find out how easy it is to update the phenotype associations with these rare diseases. Due to data privacy, we often can't report on individual phenotype data alongside genotype data, which means in rare cases, we might not learn about the new phenotypes. Who wants to take that? Henry, I'm looking at you.
Yeah, I suppose that's evidence, isn't it, that a gene is associated with a particular clinical manifestation or syndrome. We mostly learn from published abstracts, talks, or papers. I think that's where we mostly learn about these phenotypes and how it's expanded. And to do that, you need consenting patients to publish their details, and to allow you to share that with the rest of the world.
Another question from Amita Patel. Is genetic testing in cerebral palsy reserved for those who have normal MRI scans? Anna? You're on mute.
No, yeah. No, it's not. So obviously there isn't yet an established genetics cerebral palsy panel in the UK, but sort of turning this round, if a clinician saw a child who had got changes on an MRI scan, but there were other suspicions that something wasn't fitting with the story of cerebral palsy, you might still go on to do genetic testing. For example, cerebral palsy shouldn't really, the underlying condition shouldn't be progressive. So you might see something on a scan, like white matter changes, and then they might progress, and then you were definitely thinking, actually, this isn't right for cerebral palsy. I'm gonna do some genetic testing for that. No, and so you could have a normal MRI scan. And that might be suspicious, because then you think, well, there hasn't, maybe, if there's been a brain injury around the time of birth, then you might expect to see signs of cerebral palsy on the scan. So a normal scan might make you start to think, oh, is there something else that's genetic going on, and increase your chance of testing. But an abnormal scan, depending on the scan, wouldn't stop you from doing further investigations.
Thank you. David, are there any patients that you've already investigated that have benefited from their diagnosis of a genetic cause of CP?
Yeah, we in our series in the Neuronet study, there is an example of so cerebral palsy. There'll be particular therapeutic options, like splinting might be something that's typically done for cerebral palsy, but it might not be appropriate if you have a genetic form of a movement disorder or spasticity. So we've had a case where understanding the genetic diagnosis actually made for a more appropriate care plan, avoiding splinting for a genetic diagnosis. So definitely, that's one example. Claire Van Eck at University of Adelaide is now starting to look at how the genetic diagnosis might predict responses to Botox, rhizotomy, and some of the other therapies that are done for cerebral palsy patients. So we're starting to think now maybe about a precision medicine approach for cerebral palsy. Starting with a genetic diagnosis may make you more or less likely to, as a patient, to respond to the therapies that might be offered.
Can I just pick up on that precision medicine approach? Because one of the things that we've found with genomics is that common diseases turn out to be baskets of many different variants of that disease. Are we going to find the same thing, do you think, Henry, with cerebral palsy? There will be many different types revealed by genetics.
Yeah, we're already seeing that. We're seeing that cerebral palsy is really a basket of metabolic genes, movement disorder genes, epilepsy genes, and we're often in that group seeing unusual presentations of patients and things that we hadn't thought of before. So it's a learning curve that we have to keep up with, and it's a learning curve that may reveal genes that are important for treatments, as David's just suggested. So I think very much we'll see more of this, and we'll see a greater percentage diagnosed.
You were mentioning metabolic causes there, and we've got a question here from Sarah Dearman. We support children and young adults with hyperinsulinism in around half the genetics are unknown. Some of them have cerebral palsy. Should they be requesting whole genome sequencing as well as testing for known hyperinsulinism genes? We are pleased that 7 genetic types of hyperinsulinism are being screened in the Generation study. And actually, the Generation study, many of you have already mentioned that as being something that's so important for the future. David, will you take this one?
Yeah, I think it also relates to the question that Trudy had put into the chat about GLUT1 deficiency. So these are maybe metabolic conditions that put the brain under more stress. Hyperinsulinism would give you low glucose. That's associated with the particular type of neonatal brain injury. So I think they're great questions. We need to start to think about that overlap and whether that would be now considered genetic contributors to a type of neonatal brain injury that we see associated with glucose deficiency. I think based on those kinds of questions, the research will progress. We may be adding new genes to the list, and these will come into a category of vulnerability to developing brain injury and cerebral palsy, an area that we, I think, need to understand more about.
Heather, can I ask you, one of the things that people associate with cerebral palsy, as I suggested, is problems and trauma around birth. And there's often those particular cases are the subject of litigation. How does this kind of testing change that arena, and where do you think it's going?
Well, I think we have to sort of proceed with caution in cases where a family either is considering litigation or in the process of litigation for suspected negligence in a case. The way that we deal with it and talking to patients about the option of genomic testing is that they have to go into it with their eyes open, because we can't guarantee that it won't affect a litigation case if they were to have a genetic diagnosis. And so some families, given that information, may choose not to pursue genetic testing at this time. This is in research context anyway, so it's not standard of care in the first instance. But they may proceed with the genetic testing because they find that they would value a diagnosis so much that they wouldn't want to potentially compromise the possibility of new treatments for the child because of the risk to potential litigation cases. So it's a very complicated issue. There is no right or wrong answer to it. So we just try to give the family as much information as they can so they can make their informed choice about it. I would hope that it wouldn't be a contraindication to doing genetic testing to have litigation as a possibility, because as we pointed out, it's probably not just the genetic cause which is contributing to the diagnosis. So we're not saying there isn't any negligence necessarily. We're just saying this is a piece of the puzzle. But we recognize that law cases are sometimes much less subtle than that in their view of things. So I think that's how we have to deal with it right now.
David, do you think in the future that we may have panels for genes associated with cerebral palsy that are used antenatally, so that if someone does have a predisposition, then they, there is particular care during delivery, for instance, a cesarean section rather than a prolonged labor?
Yeah, that's a very interesting question. I think, for a kind of inherited genetic condition that can be a cause of cerebral palsy, we would like to offer the family genetic testing antenatally as part of their management. For a screen, which you're suggesting, sorry, frog in my throat. We're not there yet with this idea that there might be genes that make you vulnerable to cerebral palsy, and therefore should determine a kind of a more managed or controlled delivery. Is another possible approach of the future. I think we have to sort of acknowledge that we don't understand the nature of genes that might be predisposing to brain injury in a preterm infant or at the time of delivery of a full-term infant, where there may be some kind of complications. We would, in the future, I think, have a much better answer to your question. But right now, we have to put it also in the category of research needs to be done.
Yes, it's multifactorial, and of course, what this kind of research will also reveal is, I suspect, that there will be many people who might have variants predisposing them to cerebral palsy, but who never develop it. Exactly. That in itself is interesting. Another question for Henry and David, I suspect. In babies with neurodevelopmental disorders, epilepsy might be one of the first symptoms to be observed. And they then put forward for genome sequencing before other symptoms manifest. So how often should the phenotyping be updated? I mean, I know in Genomics England, we get people's clinical records. I'm not sure when we get them. Is it every 6 months or every year? Something like that. Henry, what are your thoughts?
I mean, I would like it to be every sort of year and a half, 2 years would be a reasonable timeline. Obviously, we're always a little bit pushed in the diagnostic lab with turnaround times, but that would be an ideal thing for me. And then I'd also like to, in some of those patients without a diagnosis, put them forward for the long read program, which Genomics England is currently undergoing. So I think that timeline.
What about genes for cerebral palsy that overlap with developmental and epileptic encephalopathies? And does this work that you're all doing help understand more about the complexity of these neurological disorders and other related symptoms like CP?
Yeah, I mean, I think it'd be fair to say that, the classic definition of cerebral palsy is a non-progressive condition. And it may have a cause that's more related to an impact on brain development, maybe an injury. The new understanding that there may be genetic causes of cerebral palsy will beg the question, was this actually cerebral palsy? They can often progress. They don't meet the classic definition of CP. So we are undoubtedly going to have a new lexicon to be able to, maybe better categorize patients. Many syndromes might have cerebral palsy as one factor of that syndrome. And so we may probably say this person has syndrome X, which includes cerebral palsy. But interestingly, the cerebral palsy they have might respond to a therapy that's slightly different than another person with cerebral palsy. That's the opportunity for using this information to, again, individualize and benefit care. But I'm sure within pediatric neurology, there's a lot of discussion there will be about the terminology that we're using to categorize CP patients and whether that needs to be updated.
And of course, it's as Anita Patel, as one of our viewers has said, it's cerebral palsy. There are multifactorial implications, as nice guidelines point out. It's a description, she says, not a diagnosis. So let me talk about whether people can ask for genome sequencing, and how important is it for patients to be asking for genetic sequencing? Henry.
Well, I mean, we do a neurogenetics clinic, for example, I do on a Fridays. And I would say the vast majority of those patients, I would do a whole genome as a trio or as a single case, depending on the scenario and on the family. For me, it's essential, if possible, to have a diagnosis in these patients to help me understand the management, the future, potential treatments. I think it's important for patients and families to discuss that with their clinician, because it's not just about the diagnosis. There are other things that they may wish to know and understand before consenting to have that done. So I think it's an important discussion point to be discussed with your clinician. And I think you go on the pros and the cons, but I think for me, having a diagnosis by far outweighs anything else.
Alex, is that something you'd agree with?
Yes. I mean, fortunately, in our journey, I feel like I had a very good care team that even when they didn't know, they listened to me and my concerns. But in my opinion, I feel like a lot of people are afraid to stand up to these doctors and ask them for what they want, because they think, they're doctors, they know everything. But the reality is, no one knows everything. And having a diagnosis is important, even if it's just for the sense of community. I mean, the Vamp2 community is a perfect example where, there's tons of different mutations. There's, some kids are, doing don't want to say better, but they're just different. And it's through that community that you can kind of take pieces from everyone and build your own treatment plan. And that's kind of what we're doing now as people are coming into our group. We try to buddy each other up and say, this is where you are right now. This is where, you are right now. Why don't you guys work together and then bring back, what you're learning? And I mean, our community is very unique, but I think having that sense of community and getting that diagnosis is important, even just for having someone to talk to.
And actually, one of the issues, I guess, for the future is overcoming, because you mentioned doctors, that some of them might, obviously not the ones here, might not be as receptive to requests for help as others. But one of the issues, Henry, is that cerebral palsy, clinicians do have a fixed view about the causes of cerebral palsy, and that may be hampering our progress for the future. I mean, I don't know. I don't know whether that's something that you want to comment on, because it's about educating the wider clinical population as well as patients.
Yeah, totally. Just like this webinar is doing, we're trying to educate and understand. As you say, many of the perhaps more old-fashioned clinicians are not so aware of the advances that genetics has made in cerebral palsy. So I think it is about educating. It's, I think, pushing towards having a cerebral palsy panel would be another way of educating the wider group in this country that this is an important panel of genes to test in their patients. And really, there should be, I mean, I've always preferred almost an opt-out, really, in terms of genetic testing in these patients. So I'm obviously, you're speaking to the converted, shall we say, here.
Anna.
I mean, what I would say is, in pediatric neurology, I use whole genome sequencing all the time because I see a lot of children with a lot of individually rare conditions. But I think there is a lot you can get. I mean, I know I'm for doing more genetic testing than we have done, but I think there's a long way you can go by taking a good history and thinking, okay, is there actually a family history? That is going to tell me, like, the chance of something being genetic go hugely up. Is there, are there signs that you wouldn't expect with cerebral palsy? What's going on with the heart? What's going on with the eyes? Are there some things that go, okay, clearly genetic? And then, you may be looking at other panels other than CP as well. So just good history, good examination, what investigations have been done, look at the clues. And that's important, actually, not only because, at the moment we have to decide who we're going to put forward for investigations, but also in phenotyping, because eventually, if we wanted to know how to make use of the genetic information, we need to match it properly to the clinical features so that we know how to describe what we're seeing and what people have got and how it's going to affect them in the future and things as well.
So we are nearly at the end now, but David, I want to finish with Alex, but David, just a very brief word from you. Where do you see the future with cerebral palsy and genomics?
We'll have I think new tools to be able to provide some patients answers, and we'll look forward to precision medicines. And then there are other people with cerebral palsy, and we'll continue to do research to understand the causes of brain injury, and can we also become better at neuroprotective approaches to help those kids as well. So there are great opportunities to, I think, provide new therapeutic options for patients with cerebral palsy. It should be an exciting period going forward.
I want to finish with Alex. Alex, somebody's asked, what support do you think the general public could better provide to patients and advocacy groups? And how do you think that we all can help you get a better future for people living with cerebral palsy? And unmute.
I'm just going to leave myself unmuted at this point. Can you repeat the first part of that question?
So it's just about how can the public help you to provide better advocacy? What can we do as a public?
I mean, I think that, everyone just needs to listen to the parents and the patients, in certain situations more, because when people go into the doctors and have concerns and they're pushed away, you're shutting people down when really they should be able to fight for what's important for them. I mean, there's been a handful of people that have come into our group of Vamp2, and they're being told they're the sixth patient because of one paper that was published. And we've had a specific situation in our group where that parent shut down. And it was in that short period of time when she found us again, she found my website. And now she's in our group every day and talking with us. And, the point is you can miss a lot of people if you're not doing, if you're not supporting them in what they need. That's basically what I was saying.
That's fabulous. You've done such an amazing job with Vamp2. Thank you to all of the people who've contributed today, and thank you to all of you for watching and listening. And I think one of the main messages here is to encourage people to have whole genome sequencing to aid diagnosis of neurological conditions. And we're ready and waiting at Genomics England to help do as much as we can to diagnose all of those of you with undiagnosed conditions. So thank you very much. Bye-bye.